So now we go on to treatment. Okay, and this is the medication summary that we use for the medications that we use for prostate cancer. The goal of therapy, like in all other cancers, depends upon the risk stratification. You know, it depends upon the Gleason score, the grade of the cancer. Okay, our goals, depending upon the cancer, are to achieve remission, right? To reduce morbidity or disease, and to prevent complications. Agents that are used, we got androgen antagonists. Now notice that these drugs are different from the drugs that you studied in lung cancer or breast cancer or colorectal cancer. Okay, these are now, you didn't have androgen antagonists in those cancers. GnRH agonist and GnRH antagonist. Gonadotropin releasing hormone, it's written over here. It comes from the hypothalamus and it causes the release of LH and FSH. Okay, then we have got bisphosphonates. They are used in other cancers as well. We have got antifungal, just one agent, ketoconazole. We have chemotherapeutic agents, and over here we have got docetaxel and cabazitaxel. Corticosteroids, prednisone is most commonly used. We have got some immunologic agent, radiopharmaceuticals, and poly-ADP ribose polymerase inhibitors. Okay. Right, so here are your drugs. Leuprolide, these are gonadotropin releasing hormone agonist. Leuprolide, triptorelin, hysterelin, goserelin, anti-androgens, very important, very commonly used in prostate cancer, abiraterone, bicalutamide, frutamide, nalutamide, enzalutamide, apalutamide, darolutamide. Okay, all are these bicalutamide, lutamide, and enzalutamide, apalutamide, abiraterone, very commonly used. Then these are sort of newer drugs, GnRH antagonist, they're Lupulix and Degarelix, anti-microtubular, very important, docetaxel, very commonly used. Okay, if this fails, we can use cabazitaxel. Then we have got this mitoxantrone. We have got hormones, estramustin. This is an estrogen. It is estradiol. Okay. Then we have got cellular immunotherapy, sipuleucel T, very expensive therapy. PARP inhibitors, they are inhibitors of DNA repair enzymes. Okay. So recaparib and olaparib. Bisphosphonate for bones. We have got two types of drugs for bones, zoledronic acid and denosumab. We have done this in breast cancer as well. Ketoconazole is there. This is an antifungal drug. Corticosteroids, prednisone, and radiopharmaceuticals. Alpha-radin is the trade name, and it's radium-223. Okay, so this is our drug list. Now, a treatment approach, we will look at localized prostate cancers, and for localized cancers, which have not invaded the prostate capsule, which have not gone into the seminal vesicles, okay, which have not metastasized, we assign a risk category. We look at the cancer severity, like the Gleason score, okay, the type of cells, how much changed they are, how poorly differentiated they are, okay. Then we have to look at patient values and preferences. We have to consult the family. We have to look at the life expectancy. If the patient is very old, he's 75 years old, and you diagnose an aggressive cancer, and if you give him medications which are very toxic, then it's better not to give him medications, you know. So you have to look at, if it's a young patient, he's 60 years old, 55 years old, then his life he has another maybe normally 15, 20 years more to live. So in those cases, you have to make decision what type of treatment to give him. All right. Then we have pre-treatment general function and genitourinary symptoms. You get genitourinary symptoms when the cancer is in the transitional zone and it is obstructing the urine flow. It has invaded the urethra. Okay. General function is general health of the patient. You know, you have got those ECOG performance scale. If you remember from the previous lecture, you have Karnofsky performance scale. Then post-treatment functional status, okay, the physical health of the patient. Then salvage treatment and whether it has recurred. We are discussing localized cancer. Localized cancer can also recur after treatment, or you can just wait and watch. Okay, we have different strategies. So standard treatment includes watchful waiting, which means you don't do anything. You just call the patient back after 3 months and look at the prostate level, or after 6 months. Or you can do a prostatectomy. You can decide to remove the whole of the prostate and the lymph nodes which are nearby in the pelvis. Okay. Or you can do active surveillance. Active surveillance also means don't give any treatment. But the difference between watchful waiting and active surveillance is that active surveillance is a little bit more invasive and a little bit more aggressive. Here you don't do anything except for PSA levels and general health or digital rectal examination. Here you have to do repeated MRIs, or you might have to take repeated biopsies as well. But the common thing is that in both you don't give any treatment. All right, you wait, or you can give radiation therapy. So these are the 4 options for localized cancer. Now metastasized, unfortunately, it is not curable. Okay, management is directed at relief of symptoms. For example, if the cancer is very advanced, you can give narcotics for pain relief. You can try to slow down the progression. You cannot stop the progression. You can delay it for some years, 1, 2, 3, 4 years, but you cannot stop it. So you can slow it down. You can delay it. We call it the progression-free survival. Surgical treatment for this metastatic, not very common. Okay, we can do nerve sparing techniques. You avoid cutting nerves near the prostate gland, which are involved with the sexual function. You can do laparoscopic procedures, robotically assisted procedures. Okay, so we'll not go into a lot of details of surgery. All right. Now, this is just, I've given you this because robotic, and this is a retropubic prostatectomy. Robotic, I'll show you when we do benign prostatic hyperplasia. So if you have to do prostatectomy, these are the 2 ways you can give a cut over here. This is retropubic, and you can remove the prostate, or you can go through the perineum, and because the prostate is very close to this area, so you can have 2 approaches. Now, again, androgen deprivation therapy or hormone therapy. Why is the prostate gland growing? Why do the prostate gland grow? They grow because of testosterone, right? So the prostate cancer is basically growing or becoming more aggressive because of the availability of the testosterone. So what you do is you deprive the patient of testosterone, okay? And you have different methods for doing that. You can do a surgical castration. Where does the testosterone come from? It comes from the testes. So you remove the testes. This is known as surgical castration or medical castration. You don't remove the testes, but you give drugs that decrease or that inhibit the formation of testosterone. And these drugs are LHRH analogs or antagonists, luteinizing hormone, releasing hormone. It is also known as gonadotropin releasing hormone. Okay. You have some complications with medical castration or with surgical castration. Actually, you can get urinary incontinence with prostatectomy. Sorry, this is not surgical castration. This is prostatectomy, removal of the prostate gland. So the urethra passes through the prostate gland. If you remove the prostate, you can get urinary incontinence because you have removed a part of urethra as well. You can have fatigue scores with chemotherapy, okay? You can have sexual dysfunction with radiotherapy, radical prostatectomy, even with medical treatment. And you can measure the quality of life scores or fatigue scores, feeling weak with the treatment. And here is a chart for measuring that score. This is only for your reference. We will not go through that, okay? So After a couple of slides, we will take a break. All right. So here is an algorithm for treatment of prostate cancers. So for localized cancers or locally advanced prostate cancer, you can give a curative intent. You can give a treatment with curative intents. You want to sort of eradicate all the cancer. You can do a prostatectomy for that. You can give medications for that. Or what you find is that at the very initial stage, you find that it is not resectable. You cannot give a curative treatment. Maybe it is metastatic or something. Okay. So for this, after you give a curative treatment, many times there is a biochemical relapse, which means the cancer has come back. And how do you find that? You find that by rising PSA levels. And we have seen that previously, that once you reach the lowest level below 0.2 nanogram per ml, that means that the treatment has been very good. But if after 1 year, 2 years, it goes above 0.2 nanogram, that is biochemical relapse. Okay. So you can observe, all right, that is one option. Or if it is metastatic, then you have to treat it. How do you treat metastatic? Now, HSPC means this cancer is hormone sensitive. It is dependent upon hormones. So what will you do? You will do hormone ablation or androgen deprivation therapy. Okay. You are giving those gonadotropin releasing hormone agonists. You are trying to decrease the production of testosterone. Okay. Along with that, you can give abiraterone or you can give docetaxel. These are our drugs of first choice. So what do we have this? If we say that it's not suitable because it is metastatic, but it is hormone sensitive, then these are the two drugs. Another situation is that we have got a non-metastatic cancer, but it is castration-resistant. Castration-resistant means that it is not hormone sensitive. It can grow without testosterone. Okay, that is something more dangerous. In that case, we are giving these drugs, apalutamide. These are androgen blocking drugs. Although the cancer is not androgen dependent, we are still giving these drugs. Okay. Now we go on to the next level. This metastatic, this cancer. Now here it was hormone sensitive, but now we have got metastatic castrate resistant. It is not hormone sensitive. It is growing without testosterone. Then our choices are docetaxel, sipuleucel T, abiraterone, enzalutamide, pembrolizumab. Okay, these are the drugs that we have. And these are the second line drugs, cabazitaxel, abiraterone is there, enzalutamide here on both places. Alpha-radin is radiation therapy, alpha particles, olaparib and pembrolizumab. Okay, so this is the general plan for the treatment of the prostate cancer. And what we are going to do is that we will quickly take a break, and then we will come back and we will continue with the lecture. All right. And this time we are going to take a 10 minutes break so that we come back and we quickly complete the lecture. All right. So all right, so let's resume our lecture, and hope everyone is back on their machines, on their laptops. So this is the last stretch of the lecture, and once again, I will emphasize that this is a very important lecture because this is the most common cancer in males, particularly in developed countries and in the affluent section of the population. But overall, globally, it is the second most common cancer. Okay, the first most common is the lung cancer. So we must understand the treatment, and we must understand the pathophysiology, and of course, the diagnosis and the Gleason score and all that we have done in this lecture before this session. So let's continue with the lecture. Okay, so this is a general model of treatment of prostate cancer that I've given you, and now I will take them up one by one. And there is nothing much, I'll go a bit quickly. So we first start with localized prostate cancer. It is not metastatic. It is inside the cancer, inside the prostate gland. So our options are watchful waiting, observation, no treatment. Okay, just call the patient back after 3 months, 6 months. Maybe you have done a biopsy. In the biopsy, you found that the Gleason score is just 6. So you don't need to do any treatment, okay? Or what you can do is you can do an active surveillance. You monitor, but you monitor differently this time. You are monitoring with repeated MRIs, or you are repeating the biopsies at intervals of years or months, okay? So this is active surveillance. In both of these, you are not giving any treatment. So continued PSA monitoring, confirmed biopsy. You do PSA monitoring in watchful waiting as well, but biopsy and MRI are done over here. MRI is also non-invasive. If you want, you can add that to watchful waiting as well. But most of the time, MRI is included in active surveillance. Or we have other option, which is definitive local therapy, which includes surgical therapy. And surgical therapy means you remove the prostate gland and you do a radical prostatectomy, which means not only prostate gland, you remove the seminal vesicles as well. You remove the draining pelvic lymph nodes as well. Okay. And because you have removed the prostate gland, that means you have removed a part of the urethra through which the urine passes. So you have to re-anastomose or reattach the urethra to the bladder, okay? And how do we do that? The urologist knows that. Or you can do radiation therapy after the surgery. If the margins of the removed tissue are positive, then you can give 2 types of radiation therapy: external beam radiotherapy or brachytherapy, which is implanting a radioactive material inside the cancer tissue. Right. So you can combine, for localized prostate cancer, you can combine radiation plus androgen ablation, or you call that androgen deprivation therapy. And we have seen that this has got improved survival in men with localized diseases. Radiation therapy versus surgery, which one is better? There is insufficient evidence to determine whether any type of radiation therapy results in fewer deaths or recurrences than radical prostatectomy. But you know, radical prostatectomy is a big operation. See, you're removing the prostate, you're removing the seminal vesicles, and you're going deep into the pelvis, and you're removing the lymph nodes as well. Okay, so again, it depends upon the team that is treating the patient. You can give adjuvant radiation as an adjuvant or salvage therapy. Adjuvant therapy means you have done the operation, and after the operation, you're trying to kill the remaining cells. You're trying to eliminate them. Salvage therapy means you gave a treatment, but the cancer came back. Okay, that is also known as biochemical recurrence, which I said that if your prostate level falls down to nadir, nadir means the lowest level, or it goes down below 0.2 milligram, 0.2 milligram per ml, and then it rises again. If it starts rising again after a few years, that is recurrence, biochemical failure or biochemical recurrence, okay? And then we give salvage therapy for that. So you can use radiation for that. And radiation is recommended for patients with high risk of recurrence or positive surgical margins after prostatectomy with seminal vesicle invasion, okay? Recommended in combination with androgen deprivation therapy or biochemical recurrence, okay? This salvage therapy. So these are the indications for radiation therapy. Emerging therapies, we will go into more details of emerging therapies for removing the prostatic tissue when we do benign prostatic aplasia, but there are several therapies that they are not yet recommended. But in some countries, people are doing that as primary surgical therapy. So they include whole, hemi, or partial gland ablative therapy, such as cryoablation, high intensity focused ultrasound, photodynamic therapy, and we'll go into these when we do benign prostatic hyperplasia. We'll go into more details. All right. So this is what we have done in therapy for localized cancer. You know, I gave you the medication summary, I gave you the drug list, I gave you the treatment approach for localized prostate cancer, and we evaluate that, look at the severity, patient preferences, life expectancy, urinary symptoms, or pre-functional or pre-treatment and post-treatment functional status. Then we have treatment approaches for metastatic cancer, which is not curable. Then we did a treatment approach, which is androgen deprivation therapy, surgical castration, or medical castration, or treatment of complications. I gave you an algorithm for treatment, and then we discussed different treatments for the localized prostate cancer, right? Now we go on to advanced prostate cancer. Management of advanced prostate cancer is separated into four disease states. Okay, so what I'm going to tell you is 4 types of advanced prostate cancer. Number 1 is non-metastatic biochemical recurrence after treatment. It is not metastatic. It has not gone into the bones. It has not gone into the lymph nodes, but you gave treatment and it came back. Biochemical recurrence, the PSA levels are rising again. Non-metastatic castration-resistant. It is still not metastatic, but it is not. It is independent of testosterone. Okay, it is castration-resistant. If you give androgen deprivation therapy, it still grows, but it does not mean that you stop giving androgen deprivation therapy. Okay, so that is the second type of advanced cancer. Then the next 2 types are metastatic cancers. In metastatic, we have got metastatic hormone sensitive and metastatic castration resistant, which means they are not hormone sensitive. All right. So these disease states are defined by the following. In these disease states, we look for more things. What are those things? Primary tumor status, which means, have they invaded the seminal vesicles? Have they penetrated into the capsule? Have they gone into the urethra? All right, things like that. We have discussed them. We can measure the testosterone levels as well. And we can check what therapy was given previously and what was the response to the previous therapy. All right. So we have got 4 types of advanced prostate cancers, and each type we look for these things as well. Now, biochemical recurrence without metastatic disease after we give a treatment. Biochemical recurrence is defined as rise in PSA above 0.2 nanogram after reaching a level below 0.2 nanogram or greater following radical prostatectomy. Or the second scenario could be that there is a rise of 2 nanogram per ml above the nadir, whichever lowest level you reached. After many months or after many years, it started rising again. And if it rises by 2 nanogram, we call it a biochemical recurrence. So not all men who have rising PSA will develop metastasis. The disease could still be localized. So not all of them require treatment. The risk of metastasis, it depends upon the patient's Gleason score on biopsy that we discussed in quite a bit of detail. Length of time between nadir PSA and rise in PSA. If the PSA starts rising after 1 year, that is more dangerous than the situation in which the PSA starts rising after 2 or 3 years, right? So the earlier the PSA starts rising, the poorer the prognosis is. PSA doubling time, the sooner it doubles, the worse it is. Now, management patients who have biochemical failure after radical prostatectomy, after radiation failure, and those who have got no evidence of metastatic disease, we can implement watchful waiting. We can do brachytherapy, which is implantation of a radioactive material inside the cancer tissue or inside the prostate. We can do a prostatectomy if we have not done it previously, or if we have given only radiation therapy previously. Cryoprostatectomy is an option, cryotherapy, hormone ablation. So all of these therapies are the options for advanced prostate cancer or after biochemical failure. What are the predictors? You give an initial therapy, and what are the chances that the cancer will recover? It depends upon, again, pre-treatment Gleason score. The higher the Gleason score, the worse it is. Pre-treatment clinical stage, if it is metastatic, if it has gone into the lymph nodes, it's not good. Pre-treatment PSA levels, I've given you 4 quartiles: below 22, 22 to 50 nanogram per ml, 50 to 134 nanogram per ml, and more than 134 nanogram. The higher it is, the worse it is. And pre-treatment percentage of positive core biopsies. Now, let us suppose that you take 12 biopsies. Out of that 12 biopsies, you see cancer in 8 biopsies, and you don't see cancer in the other 4 biopsies. So that means the positive rate is 66%. If you take 12 biopsies, you see cancer in 6, you don't see cancer in 6, the positivity rate is 50%. Okay, so that all these things, if they are high, the failure rate is higher. So we also consider, if it is a recurrence, we consider the initial therapy, we consider the patient's life expectancy, and we also look into the likelihood of cure, and we look at the risk of increased morbidity due to treatment. You know, all these treatments have side effects, and patient's quality of life. If the patient's quality of life is good, then we hope that the outcome will be good. But if the patient is aged and he's frail, he's weak, then obviously the outcome might not be as good. Okay. Now, next is metastatic hormone sensitive. Now it is hormone sensitive. It depends upon testosterone. The cell division is dependent upon testosterone. If the testosterone is available, the cancer cells will divide. That is what we mean by hormone sensitive. So what do? We give androgen deprivation therapy, which means we suppress the level of testosterone. How do we do that? We have got drugs, okay? Or we can do, as I said, we can do bilateral orchiectomy, which means you remove both the testes, okay? Now, this removal of both the testes or orchiectomy is not very popular in the USA and in the Europe, okay? But that is a good treatment. That is as effective as giving the drugs. Some people say it's even better than that, than giving the drugs or this androgen deprivation therapy, pharmacologic therapy, because the drugs have got their side effects, okay? So, but unfortunately, metastatic cancer is not curable, so we might have to give palliative therapy in the end. We have to measure the castrate levels of testosterone. They should go below 50 nanogram per deciliter. So we have sort of suppressed the formation of testosterone by giving the drugs that I've mentioned previously, GnRH agonist and antagonists, and also androgen receptor blocking drugs, okay? So the level of testosterone that we are trying to reach is below 50 nanogram per deciliter. That is known as castrate level of testosterone. Okay, if you reach this level, that means you have successfully reduced the level of testosterone. You have successfully reached an androgen deprivation state. So what do we use? We use luteinizing hormone releasing hormone analog, LHRH. It is the same as GnRH, gonadotropin releasing, same thing, because they come from the hypothalamus and they go to the anterior pituitary. And in the anterior pituitary, both of these, they are two names for the same hormone. They cause the release of LH and FSH. Okay, so we have got analogs and we have got antagonists. There are Localized and degarlics. So this is a part of androgen deprivation therapy. We can do orchiectomy that I have explained, remove both the testes surgically. Now we can give a combined androgen blockade therapy, which is combining GnRH analogs or this one with androgen receptor blockers, bicalutamide or enzalutamide. But this is not recommended because it has got more side effects and it is not more effective than these therapies alone. Okay, what are the adverse effects of androgen deprivation therapy? Now, when androgen deprivation means the testosterone levels are below 50 nanogram. Okay, or if they might fall to much lower than this if you do orchiectomy. So the patient will get hot flushes, loss of libido, which means loss of sexual function, erectile dysfunction, fatigue. You know, testosterone is an anabolic hormone. If you don't have testosterone in your body, you can get fatigue. Bone demineralization, you know, testosterone is good for bones. Males have got stronger bones than females. Why? Because of testosterone. You can develop anemia, muscle wasting, metabolic syndrome, depression, development of resistance. All these are the side effects of androgen deprivation therapy. Okay, whether you give it pharmacologically with drugs or you do it surgically with removal of testes, which is known as orchiectomy. Now, metastatic hormone sensitive prostate cancer, early, this is an important issue. You know, in localized cancer, prostate cancer, we have seen that we have got two options without treatment, which is watchful waiting and active surveillance. In that, we just wait. We know the cancer is there, but the Gleason score is very low. The cancer is not aggressive. So we don't give any treatment. We just wait, because if we give treatment, it is going to have all these side effects. Okay. But what about the metastatic hormone sensitive cancer? Should we give treatment or should we not start treatment? So it turns out that early treatment is much better than delayed treatment. The benefit of early hormone therapy is that it does not confer early resistance. If you delay the therapy, maybe the cancer will go away, your PSA level will go down, but the cancer will recur sooner, and the cancer cells will develop resistance to drugs sooner. That is why early treatment is recommended. And not only that, the early treatment provides significantly longer survival with fewer complications, such as pathologic fractures, spinal cord compression, ureteral obstruction, than did deferred treatment or holding the treatment, right? Now, spinal cord compression, you know, the cancer goes into the vertebra and the vertebra collapses, so the nerves are compressed. In this case, you have to do a surgery, which is known as palliative surgery, to treat this spinal cord compression of the nerves, okay? The compression of the spinal cord, right? So another option is intermittent androgen suppression therapy. What is intermittent androgen suppression therapy? You give this treatment, whatever treatment it is. Basically, it is pharmacological treatment. What is pharmacological treatment? You give abiraterone, you give bacalutamide, enzalutamide, apalutamide. You know, these are the drugs you are giving, or you can give these GnRH analogs or antagonists. So intermittent androgen suppression therapy is that you give therapy for a certain period of time and then you discontinue the therapy for some time. Okay. Intermittent androgen suppression therapy is non-inferior to continuous therapy with respect to overall survival. Okay, so it is as good as continuous therapy. Okay, intermittent therapy results in better quality of life because when you are not giving the drugs, the side effects will not be there. Okay, but now the question arises, for how much time will you give the therapy and for how much time will you stop the therapy? All right, so we have got guidelines for that. What is intermittent therapy? You give treatment for 6 to 9 months. You must give for 6 to 9 months. This is the fixed period. Or until the PSA nadir is reached, you reach a PSA which is below 0.02. Okay, so that is, these are the two criteria for giving androgen deprivation therapy. And then you stop. For how long do you stop? It depends upon the PSA level. You stop, and if the PSA is not rising, you don't give the therapy. But if you see that the PSA starts rising after 3 months, 6 months, or whatever time, you have to restart the treatment. Okay. So we are still at hormone-sensitive metastatic cancer. Addition of now for androgen deprivation, we have got other choices. One of the choices is androgen pathway-directed therapy or chemotherapy. If you go back to the drug list, we have got, I've already mentioned different therapies, which are GnRH agonist and antagonist and androgen receptor blockers. Okay, but we have got some other therapies as well. So, but remember that metastatic hormone-sensitive prostate cancer is not curable. Androgen deprivation therapy alone is no longer considered sufficient, which means that if you are giving these therapies that I just mentioned, they're not sufficient. You have to give something else in addition to that. What do we give in addition to that? It is this androgen pathway-directed therapy or chemotherapy. There are two drugs in that. Number one is docetaxel. So with androgen deprivation therapy, you add docetaxel, or you add an androgen pathway-directed therapy, which is abiraterone. Okay. Plus, you can add to that. You have to add prednisone to that because abiraterone it blocks two enzymes in the adrenal glands. The adrenal glands also produce androgens. They don't produce testosterone, but they produce other androgens. Okay, and it inhibits the enzyme 17-alpha hydroxylase, which is inside the adrenal gland. It is there in the testes as well, but you have given other treatment for that. And it also blocks 1721 lyase, which is another enzyme. Okay, so basically abiraterone is blocking the formation of androgen outside the testes. Okay, so if you combine androgen deprivation therapy, which includes orchiectomy or the GnRH agonist antagonist, it's better to combine either docetaxel or abiraterone, prednisone, or all the three drugs. Okay, depends upon the team that is treating you. Enzalutamide, apalutamide, they may increase the risk of seizures, so you don't give them to the patients who are epileptics or who are at risk of developing seizures. Okay, now ADT plus docetaxel. ADT means pharmacologic therapies, drugs, or orchiectomy. Clinical trials demonstrated the benefits of adding docetaxel chemotherapy to ADT. So the addition of docetaxel to androgen deprivation therapy is highly beneficial. All right. ADT plus docetaxel plus zoledronic acid, similar survival outcomes were seen with this combination. Why do we give zoledronic acid? We give it for the bones, to strengthen the bones, okay? Because if the prostate cancer goes into the bones, like I've given you the example of spinal cord compression, if it goes to the vertebrae in the spine, it can cause collapse of the vertebra, and for that we have to do a surgery, okay? So to protect the bones, we give bisphosphonates. Zoledronic acid is a bisphosphonate, okay? So ADT plus docetaxel is the preferred therapy. Otherwise, you can give ADT plus abiraterone. And what is ADT? Drugs or orchiectomy. Docetaxel has adverse effects because it is a chemotherapeutic agent. It is a microtubule inhibitor. Okay, if you remember, it is a taxane. So you can get febrile neutropenia. The number of immune cells, neutrophils, goes down. That happens in 15% of the cases. General disorder, including lethargy, fever, weakness, that occurs in 7%. You can get, or the patient can get GI disorder, diarrhea, abdominal pain, constipation, vomiting. Okay, so these are the side effects. So what we have done so far, we have almost come to the end of the lecture. We have looked at the management of advanced prostate cancer, which are of 4 types. And in addition to these 4 types, we look at more aspects or more parameters in each of these types. Then we discussed biochemical recurrence, rise in PSO, PSA above 0.2 nanogram. Okay, management of advanced prostate cancer. We have got different treatment modalities, including watchful waiting and all these others. Then we went to metastatic hormone sensitive cancers. Okay, so androgen deprivation therapy or orchiectomy, these are the options. I gave you the adverse effects of androgen deprivation therapy. Then in metastatic hormone sensitive cancer, should we start the treatment immediately or should we wait? The answer is that if we start the treatment immediately, that has got more benefits, or it is more advantageous than starting the treatment at a late stage. Then I gave you the definition of intermittent androgen deprivation therapy. And then in metastatic hormone sensitive, we added other drugs like docetaxel and abiraterone, prednisone. And we said that ADD plus docetaxel has got better results than other therapy in metastatic hormone sensitive prostate cancer. All right, then the last few slides. This is relatively newer drugs, relugolix, which is GnRH receptor antagonist. We have degarelix as well, which is gonadotropin releasing hormone antagonist. Okay, so that's all about it, that it is an antagonist. So when it reduces the formation or it blocks the receptor, then the formation of luteinizing hormone and follicle stimulating hormone will be reduced. Okay, luteinizing hormone is the hormone that increases the production of testosterone by the Leydig cells in the testes. Okay, so remember that with these drugs, the level of luteinizing hormone LH and follicle stimulating hormone FSH in males goes down. Okay, that is what this is. Okay, so let's go to the next slide. Now we go on to the last part and the last type of cancer, which is castrate-resistant cancer, which means it is independent of testosterone. It does not need testosterone to divide or to grow. Okay, so eventually all metastatic prostate cancers become resistant to androgen ablation. Okay, so even if initially the cancer is hormone sensitive, after some years or after some months in unlucky people, or usually after some years or many years, it will become castration resistant. It will no longer be dependent upon testosterone, but that does not mean that we stop androgen deprivation therapy. In patients with castrate serum testosterone levels less than 50, which was our objective after giving androgen deprivation therapy. So castrate-resistant cancer therapy is defined as 2 to 3 consecutive rises in prostate-specific antigen levels at intervals greater than 2 weeks. So our androgen deprivation therapy has been successful. We have reduced the level of testosterone to below 50 nanogram, but the PSA level is still increasing. So that means the cancer has now become castration resistant. So we can look at disease progression by CT scan or bone scan, or the bone pain will increase, or the voiding symptoms, there will be obstruction to urine flow, which means that the cancer is progressing, it is spreading. Okay. The general consensus is that the treatment should continue. The reasoning is that tumor cells are still hormone sensitive. Okay, some cells are castration resistant, but we still have cells that are androgen dependent or testosterone dependent. So we should not stop. If we stop, those cells will also start dividing. So androgen deprivation therapy should be continued even in castration-resistant cancers. A subset of men with castration-resistant prostate cancer will have a rising PSA but no metastatic disease. So we look for PSA doubling time. If it is less than 10 months, then it is a high-risk patient, and we should offer apalutamide, darolutamide, enzalutamide. These are androgen receptor blocking drugs. These patients should have serial PSA measurements at 3 to 6 months. They should have imaging like MRI every 6 to 12 months or bone scans every 6 to 12 months. Patients with hormone-sensitive metastatic cancer, those treated with docetaxel at the beginning of therapy have improved survival. So we said that if you start therapy with androgen deprivation and docetaxel or abiraterone at an early stage, then it gives you benefit of survival, right? So these are the approved therapies for castration-resistant docetaxel, estramastine, which is estradiol, and estrogen, abiraterone, sipuleucel T, enzalutamide, cabazitaxel. This is given if docetaxel fails. Then we give cabazitaxel, okay? And these mitoxantrone and apalutamide, these are PARP inhibitors. You know, PARP enzyme is a DNA mismatch repair enzyme, okay? So they inhibit that enzyme. Right. So DNA sequence for androgen independent prostate cancer. So we don't know the sequencing timings. This sipuleucel T, you know, it is T cells, sipuleucel T. It is a therapy with T cells. Okay, we grow the patients, we take the patient's T cells, we grow them outside and give it back to the patients. Very expensive therapy, not available everywhere. Okay. Right, so that's what we have done in castrate-resistant cancers, okay? We said that early therapy is beneficial, and we look at the rises in PSA. We do not stop the androgen deprivation therapy, but because there are still cells that are hormone sensitive, okay? And we are looking at prostate doubling times. Basically, we are measuring PSA levels, sorry, not prostate doubling, PSA doubling time. And we are looking at imaging studies like MRI and bone scans, and these are the drugs that we give. Now, the rest of the slides are self-study. I've written over here that these are self-study. Maybe I've not written it in your handouts, but the rest of the slides are not going to details. This is radiation therapy, not our field. Surgery in metastatic disease, very limited application of this. Again, this is your self-study. This you have to study, effects of androgen suppression, adverse effects. I've given you some, and these are the adverse effects. This is a table. I'm not going to read it. You have to read it yourselves. Weight gain, anemia, they are bad signs after androgen suppression. And patients receiving GnRH agonists should be monitored for diabetes and cardiovascular disease. And androgen deprivation therapy is associated with kidney disease. So, you know, initially I said you have to do creatinine, and maybe it is associated with colorectal cancer as well. For bone protection, I said we give bisphosphonate or denosumab, sorry, not denosumab, denosumab, a monoclonal antibody. We give this therapy in other cancers, and you have to give supplemental vitamin D and calcium, okay? So that is all. Rest is for your self-study, just 4 or 5 slides. And if you have any questions, you can ask me now. And that is all for today's lecture. All right. Any questions? Are you still awake?
Yes, doctor, we are there.
Okay, thank you very much. So if you have no questions, then we'll stop here. And you can, if you have any questions, you can ask me through WhatsApp. You can send me emails. WhatsApp is better, all right? So thank you very much, and I'll see you next time.